Yay. Okay, I think we're working this time. Now let me go ahead and share it. Right, welcome. For those of you who are already here, we'll get started in just a minute. I'm just sharing this into the group. Go ahead and drop a comment. Let us know where you are joining us from. Right in the comments, let us know where you are joining us from, and we would love to see where everyone is from. Okay, I think we're streaming everywhere now. All right, so welcome everyone to this week's TBI talk. Today I'm here with Dr. Perry Maynard from Integrated Brain Centers in Denver, Colorado. And today we're going to be diving into the neurologic component of headaches. A few weeks ago, we chatted with Dr. Shane Stedman about the more metabolic reasons of headaches. And then now today, Dr. Perry, we're going to cover some of the other causes of headaches, especially for folks after a TBI. So welcome, Dr. Perry.
Yeah, thank you so much for having me, Amy. I think this will be a great topic because, like you're aware, headaches are super common, and headaches post TBI are also super common, and they can be very frustrating for the patient,
Debilitating.
Debilitating for the patient and the provider.
Yeah.
Trying to figure out what to do, and I think this is really good because there's really no one treatment for headaches, whether it's just a headache that came out of nowhere or a headache post TBI. You have so many people who are like, well, you got to go to acupuncture, or I took this supplement and it helped, and I wish it was that easy. And so
Right.
my hope is today, when we talk a little bit more on other things beyond metabolic processes, the real key is trying to find out, can we find what the aggravating thing generating the pain is? I think in a future video, we'll talk a little bit more on chronic pain, which we can to then a little bit more pain science, but simply pain is just an alert that something is wrong. And so in this case, it's saying, like, can we find whatever is still insulting nerve fibers, or what are called nociceptive fibers, somewhere in the body, right? Whether those may be in the scalp, the neck, or certain aspects inside our skull. We know our brain does not have the ability to detect kind of pain, but we do have nociceptive fibers around some of the surrounding tissues and blood vessels, which is where sometimes some of these headaches can come from. So I think this will be a really good topic, and we can go through all the different drivers.
Yeah, and I think, headaches affect the vast majority of TBI folks. I know not everyone. Sometimes I meet someone and like, oh, thankfully I've never had a headache. And I had headaches even before my TBI. I know I had neck related tension headaches since I was probably high school. And it's interesting because traditional doctors really don't know what to do with headache. Here, try a pill, or my neurologist really wanted me to do Botox in my neck. And I was like, well, but Botox isn't going to fix the problem. Like, it might mask the pain, but what's the problem? Right. Like, I want it to get down to like what was causing the pain. So I think today's talk will be really interesting. We'll kind of dive into some of the different places the pain can be coming from, because it's not always obvious. Like, it's not always, people are always like, oh, I have a migraine right here, and it might actually be their neck or their shoulders or something. So
yeah, pain is a really annoying thing in that just because of where it's located doesn't mean it's there. And also, severity doesn't equate actual damage. That's the really hard part about pain is a perception. It is a threat response, and it's different for everyone. We know that, and this will come back more in the chronic pain section. We know that there's all sorts of things that affect one's pain, everything from economic status to race, to upbringing, to emotional status, to job. All these other things can affect one's pain. And
Yeah.
so that is really the hard part, is, someone just saying it hurts here and it hurts really bad. That doesn't tell you a ton. I mean, yes, there can be certain things that you'll start to clue in, like we'll talk about, of maybe vascular headaches versus tension headaches versus eye headaches, where we might clue in a little bit more, like, okay, that seems to be coming from there, but that really comes mostly from what is provocative. I think that's really the big thing with pain, is can we really understand the things that cause provocation or to make it get worse? And also, do we understand the things that possibly make it better? Because then we can understand mechanisms a little bit more to help us key in on, like, what is the root cause of this headache, to figure out, like, does manual therapy make sense? PT, massage, chiro. Does vision therapy, make sense? And so on and so forth, so that you're really getting to the root of the problem.
Mhm. Excuse me. Maybe let's start with eyes, because I think eye stuff is
Mhm.
so common after brain injury. And I mean, now the more I've learned about it, the more it makes so much sense, right? Like, especially when you hit your head. Um, and I know for me, I knew something wasn't right with my eyes, but like my acuity was fine. I could see fine, well, mostly fine, but I knew something wasn't quite right with my eyes. And, I felt like I had eye strain.
Mhm.
Um, and again, doctors just kept telling me everything was fine. Till I'm, found functional neurology. Uh, so let's talk a little bit about eyes
Mhm.
and how they can play a role in headaches.
Definitely. I think one of the biggest places that you see eyes play a role is in photophobia or light
Mm,
sensitivity. So that's a real tricky one. A lot of patients where they're like, I can barely use screens. So some
yeah,
individuals may just have issues with artificial light. So computer, TV screens, the awful LED lights in businesses or the grocery store.
love
Yeah.
my blue blockers.
Some people even have issues with natural light.
Fun.
So, when you're looking at photophobia, right? So there's some different theories, but really we have these photoreceptors in our eyes. You hear these talked a lot about in the circadian rhythm realm, but that have to do with circadian rhythm. So we're always picking up different wavelength frequencies. And so there are some different theories of how light can be affecting pain, into, irritation in the eye, the optic nerve, all the way to how light ultimately is being processed in different parts of our brain, specifically a part of our brain called our thalamus. And our thalamus is a huge central relay station for just sensory information, whether that be pain, whether that be light touch, whatever it may be, but it also interprets things like light. So photophobia is a really, really big one to consider. Once again, most of the time, these are individuals who are using screens and they have headaches. They're going out light, they need sunglasses, things like that. Another big reason where the vision can create headaches, like you said, is eye strain. So anytime we're looking at the eyes, like you said, of course, people are always looking at acuity, and more often than not, those things are normal. But the question is, are the eyes one on a level playing ground? So, like, are they working together? And are they tracking smoothly and efficiently? So we know in some brain injury cases, we're not using our eyes very well together, right? So we may be using our right eye a little bit more than our left eye. And the problem with this is that, right, we have muscles in our eyes just like we do in our neck and our body, right? And these muscles can create strain and they can create referred pain. So that can be an aspect. The other is just irritation to, like we talked about, that sensory processing part of the brain. So if we're looking at that thalamus and it gets a lot of input from our eyes, and maybe my right eye is telling me one thing and my left eye is telling me another, and my visual world is just very overwhelming, that is going to change centrally how my brain just perceives anything, right? And so that could lead to dizziness, that could lead to pain, because all those things are just perception of a world. So,
Right.
The eyes can create pain just because of strain in the eye muscles themselves, because they're just not efficient in working. It can overwhelm and overload the brain, leading to pain. And then the other piece is our eyes are very hardwired to our neck, right? You could even do an
Yes.
experiment. If you put your fingers on the back of your neck, you look left, you look right, you look up, you look down, you'll feel your neck contract. And this makes sense because our eyes and our neck have to work together to be able to scan our environment. So it's not uncommon that you might see someone tracking and their neck is starting to spasm, right? Or their neck is playing a huge interplay. So there's a huge interplay between the eyes and the neck and the eyes. And so you may be having someone where their tracking is really not good and it's creating a lot of neck tension, leading to technically like a cervicogenic headache.
Yeah.
But you could treat the neck all day long with chiropractic, massage, acupuncture, and it gets relief, but it keeps coming back because the root cause is the issue with the eyes and how they're tracking. So right off the bat, we can see that visual issues can create headaches, but for multiple different reasons. So photophobia, throwing off the neck, not moving well together, or just overwhelming the brain with really bad info, leading to something like a migraine.
And I just want to pause for a moment because that was a lot. But I think you made such a good point towards the end. Like, so I know a lot of people get headaches, they go see their chiropractor, they get an adjustment, might feel better for a day, but then it all comes back. And it goes back to what you're saying. Like, if the root problem is the eyes, the adjustment isn't going to help, or it can even flare it up and make it worse.
Mhm.
So like getting to someone like a functional neurologist like you, who can like kind of dig in and delineate between, you know, the different programs of your brain, so to speak, right? And get to that root, like what is causing. And um you know, uh I'm going to say I'll link a different video in here where we talked in the past about functional neurology and all the different testing that you guys go through. So I'm going to try and link that in this video description so that people can find that one too, because I think that's really helpful to know how you guys are so different from a traditional doctor or even a neurologist, right? And how
Mhm.
you guys do things so differently. Because my neurologist, I remember telling her, I think my eyes are causing my dizziness. And she's like, oh no, that's not possible. Like, as I make you spit out your water, because like
Yeah.
that's 90% of the problem for a lot of people. So to have a neurologist tell you that, and then to learn later on that that's not true, like, you know, it's frustrating. You get all this conflicting information. And I know I've been seeing that come up in the tribe lately, of like, okay, so you guys are telling me I need to find a totally different doctor now. It's like, well, yes. You kind of have to get outside of that traditional healthcare system sometimes.
And that's a very hard thing. I was talking with someone very close to me, about someone I know relatively close, and they're kind of going through that traditional route, and it can be hard because you kind of know what's going to happen, and you can kind of predict what's going to happen, and sometimes you just have to wait for individuals
Yeah.
to come to that at their end. It's an unfortunate that for most people they need to fail a traditional route to get there,
Yeah.
is going there first, because I think another big thing about functional neurology that is really key is that it's not that it's this or nothing. I think we have such an ability to really understand what the patient needs. So going back to the eye situation, I had a patient recently and has just had these debilitating headaches for most of his life. He got sinus surgery, it went away, and then they came back, and we did some work for a while and there's really no change. And then one day I was redoing some tests and I noticed once again with far and close eye movements, like he was like, I think that kind of aggravates the headache. And I started looking into it more, and we found some other eye stuff. And actually, I ended up sending him to a neuro-optometrist I work closely with, and they did some work, and I got an email back from her like 2 months later, and she's like, his headaches are gone. And so that's the other piece that a lot of people don't realize, is that I think we're really good. Technically, I think we're really good general practitioners for brain issues. in
Yeah.
that whether we can help them, but I think we have a better handle on knowing where to send them next. So I think that's really the key is people think of us
Yes.
as just like when all else has failed, go to them. What makes more sense is have a team, but we're able to once again guide to figure out like, does vision therapy make sense? Does once again, there's plenty of patients I have where it's like, you know, you got to go to a traditional neurologist because here's the things we need. Versus unfortunately, the other side is that a lot of that's not taken into consideration. So I think that's a really important point you make, that people think they just need to come to us once they've failed everything else. The problem is like,
Unfortunately, it takes them doing that
yeah,
to finally.
and the unfortunate part when we're talking about pain syndromes, the longer they're around, the harder
Yeah.
they are.
Yeah.
That's just, and that's supported in science, right? We know, and we'll get into this when we get into the chronic pain, you start to develop all these other things secondary to the pain. So the quicker you can get to the root of it and get rid of it, there's going to be a much better and quicker outcome. So
Yeah. Yeah. All right. Let's talk a little bit about the neck. So I
mhm.
know the neck is another, like I said, mine were neck issues before my TBI. Um, and I know a lot of folks suffer a whiplash injury with their brain injury, right? Like they've had a car accident or fall of some kind that they also have a whiplash injury on top of a brain injury. So let's talk about the neck and headaches a little bit.
Yep. The neck is super common. And I think this is something that gets overlooked more than it really should with how common,
Yeah.
but like you said, whether it be a whiplash injury, whether it be a vestibular injury that has now created a neck issue, which can happen, a visual issue that has now created a neck issue, or you've affected the parts of your brain that have to do with coordinating movement, so your neck's really tight. So, really some of the big ways that the neck can generate headaches or some of these referral patterns are, right, we have all sorts of nerves that run out of our neck and they innervate, the front of our neck, the side of my face, in front of my ear. These are all those charts where you see some of the referral patterns for like the occipital or the greater occipital, the auricular nerve, and all these different nerves that innervate. And so that's where you might have someone where, they got a headache up here, but it's really coming from a muscle down here called their SCM. Or once again, sometimes when individuals have a lot of issues in the base of their skull or their suboccipital region, it's not uncommon for individuals to have pain, in the front of the head or wrapped around the jaw. I kind of lump the jaw into the cervical spine. They work very much hand in hand together. And when one is messed up, the other's messed up as well. The jaw is another big referral pattern when some of the muscles, once again, whether it's the temporalis, which runs up into here, the masseter, the medial pterygoid, which is inside. So a lot of times if people have ever had some of the releases intraorally, like I said, what happens a lot of times if those muscles go into spasm, they start to irritate. So like if we look at how a nerve generates or can generate pain, is that if we can get compression. So if the muscle is really tight, can compress the nerve, and that can create either a little bit of hypoxia to the nerve, which will irritate and then create pain, or it can cause once again like a backup in blood flow or just that mechanical irritation. And then the problem is when that pain goes, that pain then generates more muscle tightness, right? And you can see this loop go on, and it's not uncommon where if you can get the pain to calm down, sometimes you'll feel the neck release or the jaw release. So
Right.
it becomes this vicious cycle of the neck gets tight for whatever reason, which we talked about a lot of times is vision, vestibular, or an actual direct neck injury. And then that pain starts to irritate things. So the neck goes into more spasm. Then individuals move less. They get hesitant to move their neck, so it gets tighter, and then it becomes this vicious cycle. And so a lot of times early on, we want to try to decrease the pain as quick as we can to kind of de-escalate that threat. But then we got to do things to get that neck loose. And maybe that is chiropractic, maybe that is PT, maybe that is massage or acupuncture. But if we're talking about TBIs, more often than not, one of the things that happens is proprioception can get thrown off into the neck. So I explain it to patients this way, is like, think of the muscles and the sensors in your neck as like the dial on a radio. And if it's really clear, you go through all the radio stations and you hear them crystal clear. Or you're like me this past weekend where I was driving from Dallas to Austin, and in between the radio selection's awful. And there's like nothing, everything's static. And so for a lot of individuals with whiplashes or concussions, that input coming in is static. And so if the input coming in is static, your brain's ability to, one, interpret pain there is not very good. And then its ability to control it very coordinated is not very good. So now you move your neck very jerky, and so the muscles get into spasm. So part of helping a headache might be doing things to improve proprioception or to clean that dial up a little bit more so it's clear, so that then your brain can create a more coordinated movement, your neck loosens up, it takes off compression off some of those nerves radiating to your head, and then you can see the headache get a lot better. So you can see where a lot of times manual work, just loosening, like muscles are tight for a reason.
Right.
You know, I was talking to another provider in here about that, you know, and a lot of people don't get that. It's like, just stretch. And it's like the brain puts tightness in muscles for a reason, whether it's guarding something or whether that's just what it thinks it needs because of where it thinks it's in space.
Right.
And if you change that, a lot of times you can see tone of muscles totally change, and you didn't do anything to stretch it, or you didn't do anything to adjust the joint, but you gave the brain better feedback. And by loosening the neck via finding the root cause, a lot of times cervicogenic headaches will get a lot better.
Yeah. And am I remembering this right with some tape? Like you would put tape, rock tape on parts of the body to help the brain get the feedback that's there?
Yeah, I'm
explaining it poorly.
No, you're doing a great job. Yeah, when you look at some of the different theories of tape, and some of the tapes work different, is one that is the thought is that it creates a little bit of tenting in the skin so that it will increase like lymph flow and blood flow. So there's some local aspects. It's been shown to improve like muscle fatigue and endurance. So like it takes longer for the muscle to get to fatigue point for whatever reason. And then the other big piece is I find it just acts as like an external hug to the joint, right? It's turning up the dial to the brain to say, hey, here's this joint in space. You know, if we look at like the low back has very poor representation in the mapping of the brain. And there's some theories of, is the low back and chronic pain, do those things go so hand in hand together because the representation of that limb or that area is just not very good, right?
Right.
So versus our hands and our face have amazing, huge representation. Our low back has very poor representation. And so when you look at some therapy approaches, a lot of times they are to bring awareness to that area, whether that be body scanning, whether that be tape. And who's to say that massage, chiropractic, acupuncture, all those things don't work, because you're kind of saying, hey, brain, here's where this joint is. It does exist. And then the brain can be like, oh, there it is. Like, let me modulate a little bit better, because we know that in chronic pain in the low back, that already small map becomes smudged. And so the same thing most likely happens in the neck, in that if we might have a clear picture, and with more and more injury, that map becomes harder for your brain to detect, which is going to make it very hard to control blood flow there, but also to modulate pain there. So that's kind of a long-winded way of kind of how tape can really work and really be helpful in pain.
The whole low back thing's fascinating. I've never really heard anyone say that before, and how in the brain map it's not as represented because so many people have low back pain.
Yeah.
So
yeah.
That's I'm segueing, but that was fascinating to me.
Yeah. There's a lot of work. I remember I was super into maybe like 10 or so years ago, and this is where you started to have I'm blanking on the two researchers' names. They wrote a bunch of books, but this is where they started doing like you started to get some like the mirror therapy, graded motor imagery. So we use this a lot where you're doing like left-right discrimination. So you see a body part and you have to figure out like, is that left? Is that right? Is that upside down? So you're having to learn to interpret and imagine that body part. And is Mosley and someone else were a lot of the people who were big in that work early on, and looking at the poor representation in the homunculus, which is kind of that map that people might be familiar with, where it kind of looks like a monkey with the big lips, the big face, big hands, and the leg kind of wraps around our brain like that.
I remember early in my work in Funk Neuro, I had an app and it would show you the body part and
Yeah.
you'd have to say left or right. And
Yep.
it like you had to do it as fast as you could. And I hated that thing at first. And then it got really easy. I was like, oh,
yeah. I use Recognize Me a ton.
yeah, that was it.
Especially when I'm trying to get patients to have a better idea of a limb, because you'll find, and this is what some of the
Especially like with stroke.
yeah, and this is what the research has found, is that individuals with pain in a limb a lot of times have more difficulty than healthy individuals without pain in understanding left versus right. And it gets more complicated, right? You start with the vanilla level, and then you get to abstract, and it gets harder, where it's more it's more abstract, and it becomes harder to get the context. And so it's really forcing your brain. And so I think the thought on that is that when you have pain and people have issues with left-right discrimination, there's something going on where they have lost the ability to understand that body part and the ability to manipulate it in their brain.
Well, I think this conversation has been really enlightening for some folks because, like I said, headache is such a complex issue. And for individuals who maybe never had headaches before their brain injury and now like they're debilitating and doctors don't know what to do with it, it can just really be debilitating. And, the old adage of telling people to just go stay in a dark, quiet room for, weeks. And now we know that that's really antiquated and that's not the answer. Right after a brain injury, you should do activity as tolerated. What does tolerated mean can be kind of up for debate to some degree too. But, so someone watching who's having a lot of headaches, what advice do you have? Like what are, my thing is like, I think you should have a headache log and a food log. Like that should be like number one. But what's some advice that you would give people who are struggling with headaches, like some next steps?
Yeah, I think if you're having headaches and the only course you've taken is medication, once again, there's nothing against medication. Some of the migraine medications and CGRP medications can be super effective. But if you've kind of gone from like 0 to 60 and you haven't explored some of these other things we've discussed, I think that's really important that you explore, like, okay, could this be a cervicogenic headache? Could this be a headache coming from my eyes? We didn't talk about this, but cerebral blood flow is a huge one post concussion. So like this presents really in the way of individuals who get worsening headaches with exertion. Might get a headache with like lying and standing or exercise, right? And this is actually a kind of a sign of a more difficult to recover from head injury. So a prognostic factor for a longer recovery is headaches with like exertion. And the thought is because cerebral blood flow has been dysregulated. So once again, looking at these different things like blood flow issues, neck, eyes, so I think that would be my one thing, is that if that's kind of the only approach you've taken, find an individual that understands the whole picture to see if more can be added to it, and I think the big thing is also remembering, and it's very real, but recognizing, it's like also pain does not always equate threat. And if you're an individual with pain and you're starting to notice like you're not doing things you love quite as much, depression is setting in, you're avoiding these different things, you feel like you can't get better, these start to be kind of warning flags of, that you're starting to see some of these central pain things seeping in. And that's where sometimes things like cognitive behavioral therapy or some of these other aspects Or once again, just saying like, hey, that's really a time to really start trying to find help, versus like a lot of times, like just wait it out. Let's see over 6 months, So I think that's the big advice is just if there's really not been much testing done and it's just been throwing medication and medications are failing, find an individual who understands how to really diagnose different types of headaches and different causes and see if you can find more of the mechanism and find a therapy to get a little bit more to that root.
Mhm. And so, anyone watching who is interested in learning more on working with you at Integrated Brain Centers, I do have the link below, but they can schedule a free consultation with you. So tell us a little bit about that.
Yep. So we do free consultations for individuals all over in Colorado and outside the country, even kind of around the globe. And those are really good because that helps us to review the case, see what's going on, see what you've kind of done. Just like we talked about, a lot of times we'll talk to patients and they're like, man, I've done everything. And then you kind of hear what they've done and you're like, no, there's a whole bunch that you have not tried yet,
Right,
which honestly I find to be super empowering. When
right.
individuals call and they've done everything I'm thinking of, I'm like, ooh, okay, this is a little bit harder versus they're like, I've done everything, they've run everything. I'm like, now there's still like a dozen things that we have to rule off or take off the table. So those appointments are really nice for that. Or sometimes it is, I'll chat with people all around. I chatted with some individuals in New Jersey and the East Coast, and sometimes it's also helping them to find a really good provider near them. Because just like we talked about, not all providers are created equal. And part of the hard part is finding who is really well suited for different types of cases.
Yeah.
And a lot of times people don't know. And usually if doctors can't help, they don't help find them someone who can. They just say, I can't help.
Hmm.
So good luck. And what we try to do is, even if we can't help, say like, let's try to find someone who can help. And let's go through, let's see what other providers have to say. And let's help be your health liaison to say, hey, that makes sense, or hey, that doesn't make sense. So that we can try to save individuals time and money and
Yeah,
get to the appropriate provider quicker.
yeah. So important. And I know I come out and see you once a year for my annual tune-up, which I'm due. I am due. I need to get out there. Um, but thank you, Dr. Perry, for being here today. Again, I have the link below if you want to schedule a consultation or just reach out with any questions you might have. If you're watching the replay, drop a comment, let us know if you have any questions. But thank you, Dr. Perry, so much for being here today.
Yeah, thank you so much, Amy.